Good afternoon. This is the second part of my lecture about the complications of glaucoma filtering surgery. In this part, we are going to discuss the early post-operative complications and events that may happen in the very critical days after the surgery. There are very important instructions that should be given to the patient. First, the patient should avoid rubbing his eye completely and should avoid strenuous efforts and leaning forwards for at least 2 to 4 weeks till stability of healing of the tissues occurs. Also, the frequency of follow-up depends on the intraocular pressure. Either it is good, very soft, very high, the anterior chamber depth, this is very important, and the bleb characteristics. These variables dictate the frequency of follow-up of glaucoma filtering surgery. And one of the adverse features of glaucoma filtering surgery is that frequent follow-up visits are often required. The first serious problem is the early post-operative hypotony. This is very common in glaucoma filtering surgery, especially with the use of mitomycin C. Those cases will be divided into two major categories: cases with shallow anterior chamber and cases with normal depth anterior chamber. Shallow anterior chamber can occur either due to excess filtration under the flap or conjunctival leak, and those two major causes can be easily divided by looking at the height of the bleb and doing Seidel test, as we are going to show just in a moment. Also, there may be serous cilio-choroidal detachment. This is also very common, and cyclodialysis, especially if the procedure is accompanied by trabeculotomy. Those two causes can be differentiated by looking at the fundus of the patient. So that fundus examination is very, very important in cases of post-operative hypotony after glaucoma filtering surgery. If the anterior chamber is not shallow, this can occur due to either transient ciliary body shock, and this is common in patients who do not stop the anti-glaucoma medications few days before the surgery. This is very important to look at. Also, some patients develop retinal detachment, especially cases of silicone-induced glaucoma who have done vitrectomy and silicone oil injection, silicone oil removal, several retinal surgeries before. This is common to happen. The grades of anterior chamber loss: this is the normal depth of the anterior chamber. There is no iridocorneal touch and the angle is open. Grade 1 is a partial touch between the iris and the corneal periphery. Grade 2 is total touch between the iris and the cornea, but there is no cornea lens touch. Still, the cornea and the lens did not touch each other. Grade 3, or total loss of the anterior chamber, there is touch between the cornea and lens, and this is very dangerous because in few days you will get a cataract and corneal edema that may last for a long time. So that this situation should not be allowed, and if happens, it should be managed very quickly. Excess filtration or flap leak. In this case, we will find hypotony, flat anterior chamber, as we have said before, but the aqueous will migrate in excess from inside of the eye into the subconjunctival space, so that you will get high bleb and negative Seidel test denoting no leak from the conjunctiva. Usually it resolves spontaneously. If accompanied by grade 1 or even grade 2 loss of the anterior chamber, you can wait up to 3 weeks till healing is significant and filtration is controlled. Of course, the patient should avoid rubbing his eye, leaning forward, and any straining. If this condition is not treated, you will get, as I said before, touch between the lens and the cornea. This will cause corneal decompensation and cataract. Hypotony also may be complicated by maculopathy. You will find choroidal folds, macular edema, and sometimes disc edema. So it is very dangerous. Cilio-choroidal detachment can occur, causing more hypotony and more persistent hypotony. This condition should be managed either by topical steroids and cycloplegia. if it is grade 1 or 2 loss of the anterior chamber, and without these complications. Tight bandage or bandage contact lens can be helpful in these cases because they press on the flap and reduce the filtration. Filling the anterior chamber with viscoelastic, I prefer in these cases Helon GV, not the ordinary Helon or methyl. Also, we can inject air or expulsile gas in the anterior chamber. Finally, we can resuture the scleral flap, and if there is any tear in the flap, it should be dealt with in order to restore the intraocular pressure, because hypotony is very serious. It is even more dangerous than glaucoma itself. Conjunctival leak is very, very common. In this case, we will find hypotony, flat anterior chamber, but the bleb will be flat because all the aqueous will escape from under the conjunctiva into the tear film. Seidel test is done by touching the suspected leaking site by sterile fluorescein paper, and you will see that the aqueous humor flow out from the subconjunctival space. It may occur from a surface buttonhole in the conjunctiva. This is difficult to suture in many cases. We have to use either bandage contact lens or tight bandage. Sometimes aqueous suppressants help because the continuous flow of aqueous humor prevents healing. So when you suppress the aqueous formation, you give a good opportunity for healing of these buttonholes or leaking sites. Also, we can use antibiotics that induce conjunctival fibrosis like gentamicin and tobramycin. This also can be helpful in some cases. If leakage occurs along the incision line, you have to decide. If it is minor leak, you can observe, you can apply bandage contact lens, you can apply a tight bandage, and sometimes if there is total loss of the anterior chamber, you have to resuture. This case of lost anterior chamber for few days, and you can see here corneal edema occurred. In this case, we added sutures, one suture from this side and one suture from this side. Then we test for leakage. Adding suture is not enough. We tested for leakage and we found leakage from this spot. So we have to suture the leaking site. I prefer to use inverted sutures because the 10-0 sutures knots are very irritant to the patient. So the inverted suture makes the knot under the conjunctiva, and we test again. So now there is no leakage. Now we are sure that leakage has stopped, so we can leave the patient. Of course, we can add viscoelastic at the end of the surgery in the anterior chamber. It is not sufficient to suture, but you have to test for the tight closure and the water tightness in these cases. Cilio-choroidal serous detachment is also very common after glaucoma surgery. It can be a complication of hypotony itself, so that conjunctival leakage or excess filtration can induce cilio-choroidal detachment. This will cause more hypotony and persistent hypotony. Sometimes the detachment is very high, causing the kissing choroidal folds, and this situation needs urgent interference. If the choroidal folds are not touching each other in the middle, you can wait for a spontaneous resolution of this complication. And it usually resolves within 2 weeks to several months. So if it is not accompanied by hypotony maculopathy, hypotony disc edema, or kissing choroidals, you can wait for the patient. And this is the vicious circuit. Hypotony induces cilio-choroidal detachment, causing ciliary shutdown, causing more hypotony. Hypotony can be initiated by either conjunctival leak, excess filtration from the flap, or aqueous suppressants before surgery, so that the patients should stop all the aqueous suppressants a few days before the surgery in order to minimize the risk of this complication. Serous cilio-choroidal detachment can be managed either stopping the aqueous suppressants if they are still used. Sometimes the patient continues using his pre-operative medications by himself, if you do not stress on him that he has to stop these medications. Frequent use of topical steroids and mydriatics, very helpful. Sometimes systemic steroids are needed, and if not resolving or if kissing choroidal folds, you can drain this serous fluid by inserting an anterior chamber maintainer in the anterior chamber and the trocar into the supra-choroidal space. The pressure of the irrigating fluid will push out this serous fluid. Instead of inserting a trocar, we can make two scleral incisions. Each one is about 5 millimeters in length, one in the lower temporal quadrant and one in the lower nasal quadrant. These incisions are done 5 to 6 millimeters away from the limbus, so that they allow for the egress of the supra-choroidal serous fluid. And this is very efficient if you cannot apply the trocar into the proper situation. Now the second possibility is having post-operative very high intraocular pressure. So some patients develop hypotony, some patients develop high intraocular pressure. Again, those cases will be subdivided into two categories: cases with shallow anterior chamber. In this case, the most common cause and the first differential diagnosis is pupillary block glaucoma due to incomplete iridectomy. In this case, you will find iris bombay with anterior chamber shallower in the periphery than in the center. The second possibility is supra-choroidal hemorrhage, and this is a very serious complication, and we are going to discuss in a moment. The third possibility is malignant glaucoma or aqueous misdirection, and this will be discussed in details now. Also, we can find cases with high intraocular pressure and normal depth of the anterior chamber. This means non-functioning fistula. This means that the fistula is not filtering anything, and it can occur due to either tight flap closure or obstruction of the inner ostium of the flap, either by incomplete iridectomy, vitreous prolapse, fibrin, blood, Descemet's membrane, the lens capsule, so many possibilities. So you have to look to see what is the cause of obstruction. Of course, fibrin and the blood will disappear spontaneously, and the fistula will work in 1 week or even more. But the other causes should be surgically corrected as soon as possible. So that we have cases with postoperative high pressure, either with shallow anterior chamber or normal depth of the anterior chamber. Again, the most common cause of postoperative high pressure with shallow anterior chamber is the pupillary block. In this case, you will find iris bombay. Malignant glaucoma or aqueous misdirection, this is a mysterious event. This is the normal aqueous circulation. If the patient suffers from sudden shallowing of the anterior chamber, this will cause anterior rotation of the ciliary processes. In this case, the ciliary ring will be obstructed by the anterior vitreous face. So there is any cause of sudden shallowing of the anterior chamber can induce a forward rotation of the ciliary processes in a way that it will be blocked by the anterior vitreous face. In this case, the aqueous humor will not be able to pass to the posterior chamber and through the pupil to the anterior chamber. Instead, it will pass to the vitreous, causing alteration of the vitreous volume. The altered vitreous will push the lens forwards, causing uniform shallowing of the anterior chamber in the center and periphery, in contradistinction to pupillary block glaucoma, in which the anterior chamber will be shallower in the periphery than in the center. So this event is diagnosed by exclusion of pupillary block glaucoma. You have to exclude pupillary block glaucoma at first. The causes of sudden shallowing of the anterior chamber, as we have mentioned, include glaucoma filtering surgery itself, conjunctival leakage excess filtration, removal of releasable sutures, opening the tubes of Barveld implants, etc. This trauma, penetrating trauma of the eye, this can be complicated by these events. This is not common, but you will find that the anterior chamber is uniformly shallow after surgery, and if it happens in one eye, expect it in the other eye. It is diagnosed only after exclusion of pupillary block glaucoma, and I'm repeating that the anterior chamber in malignant glaucoma is shallow in the center and the periphery, in contradistinction to pupillary block glaucoma, in which you find iris bombae. The intraocular pressure can be normal in some cases and can be very high in some other cases. So the intraocular pressure range is very wide in this condition. Treatment resolution of this condition is defined as deepening of the anterior chamber plus control ventricular pressure. Deepening of the anterior chamber is important. It means that aqueous humor has regained its normal circulation. So management is aimed at deepening of the anterior chamber and control of pressure, not control of pressure only. Cycloplegia, it will cause relief of cilio-choroidal block, and it may be required for several months. It is not easy to treat these cases. Anti-glaucoma medications are prescribed if the intraocular pressure is high. Peripheral iridectomy sometimes is done not to treat malignant glaucoma, but just to exclude pupillary block glaucoma. So the criteria of diagnosis of malignant glaucoma is the presence of patent iridectomy. So if you are not sure of the patency of the iridectomy, you can make YAG iridotomy just to exclude the possibility of pupillary block glaucoma. If the patient is aphakic or pseudophakic, we can do YAG capsulotomy plus anterior hyaloidotomy. We don't open only the capsule, but also we have to disrupt the anterior vitreous face in order to allow free passage of the aqueous humor from the vitreous chamber into the anterior segment of the eye. If the patient is phakic, sometimes we do peripheral iridectomy and anterior hyaloidectomy. We go with the probe through the peripheral iridectomy and cut the anterior hyaloid and anterior part of the vitreous. This is difficult to be done, and it requires small gauge vitrectomy probes. This may allow free circulation of aqueous humor from the vitreous cavity into the anterior chamber. If pressure is still high, we can do diode laser cyclophotocoagulation if a vitrectomy is not sufficient to control the intraocular pressure. This condition is very mysterious, often overlooked and mistreated. And thank you very much.